Welcome back. This is Dr. Jin Sung, where clinical excellence meets excellent results. Today we're going to talk about iron deficiency anemia, some of the signs and symptoms, what are some of the causes, and then in part 2 we're going to go over the differential labs that can diagnose you with iron deficiency, as well as going over remedies, treatment options that are available to improve iron levels for yourself. Okay, so we're going to go right into it. Let's go into iron deficiency anemia, hair loss, fatigue, etc. Right? There are a lot of signs and symptoms for iron deficiency anemia. So, what are some of the reasons why someone who may be iron deficient? One is the lack of intake or the lack of absorption of iron. So you might be taking in iron but not absorbing it correctly, or you might be lacking the amount of iron that is necessary. So number one is malabsorption. Why would we have malabsorption, right? Some disease process or autoimmune processes will damage our gut lining to the point where it does not absorb nutrients very well, iron being one of them. So when we look at things like Crohn's disease, irritable bowel disease, celiac disease, or even ulcerative colitis, you're going to have malabsorption of nutrients, and you can develop iron deficiency anemia because iron is one of those things that is necessary for proper oxygenation, right? Another is antacids. So antacid use is very high here in the United States. Whenever you have a reflux sign or burning, they give you an antacid. But what patients don't really realize is that antacids should be used short term, not long term. So sometimes patients come in and they're on antacids for 2 years, 3 years, even 10 years. So why is antacids creating malabsorption? Basically, you need stomach acid to break down your foods, right? Your fats, your proteins, your carbohydrates. If you cannot break down your fats and carbohydrates, etc., and the acid that you need is lowered because of antacids, then you will not break down the components and not absorb it correctly. So you may lack B vitamins, you may lack iron, right? So antacid will create malabsorption of your nutrients. Other things are surgeries, right? Surgeries like gastric bypass or small bowel dissection because of, let's say, Crohn's disease. So definitely surgical procedures can contribute to malabsorption syndromes. The other is consumption is low, or low consumption. What that means is for a lot of children here in the United States, they grow up on cow's milk. And what happens is rather than eating food as they get a little older, right, they start to just drink milk, right, 4, 5, 6, 7 bottles a day. And they're getting the calorie intake, they're getting the vitamin D and calcium, but they're not getting their iron, right? So kids who drink a lot of cow's milk can develop iron deficiency. Now, cow's milk is very different from breast milk, where breast milk would provide all the necessary ingredients or nutrition for the child. But as they start to wean off and they're on cow's milk for a long period of time, they will develop iron deficiency. The other one is vegans and vegetarians. And we're going to discuss this in detail next time, but basically vegetarians and vegans, they're taking in non-heme iron, basically, right? And it doesn't absorb as well as animal-based products, such as red meat or even seafood, etc. So vegans and vegetarians are notoriously low on iron and B12 and B9, etc. So it's very important for vegetarians and vegans to check their iron levels correctly and then supplement as necessary, okay? So there's another reason is loss of iron, right? We call it hemolysis or hemorrhagia. Basically, you are either breaking down your red blood cells too quickly or you're losing your blood somewhere, okay? Here are the causes. Heavy menstruation. So when women get into the age where they're menstruating, about 10% of those people will actually develop iron deficiency, right? Because of irregular menstruation, heavy menstruation, right? Endometriosis is another reason. Large hemorrhoids or multiple hemorrhoids that cause a lot of bleeding can lead to anemia. GI bleeds. So GI bleeds can occur due to ulcers, right? Or like things like Barrett's esophagus where it starts to erode things. But NSAID usage, right? Pain medications, aspirins, ibuprofens, right? They can cause damage to the GI lining if you're using it for long periods of time. And then it would have a slow GI bleed that you are unaware of and lose iron, right? Also cancers, nosebleeds. So people who get frequent nosebleeds for whatever reason will tend to develop some form of iron deficiency. Another one that people don't really realize is that urinary loss. People have blood in their urine, they don't realize that, right? It could be from a bladder infection or a small kidney infection. So you could lose blood in the urine, so you should check your urine to see if there's any blood loss and make sure to rule these things out. Increased use of iron, right? So when we have child development, as you're growing rapidly, you're going to use more iron, right? Because you need to grow. So growth and development is a big thing. And also when the mother gets pregnant. So the mother is providing the baby or the fetus with all this nutrients. And basically you're feeding two people. And if the mother is not on a proper diet and they're not supplementing at times, especially in the third trimester of pregnancy, they can be iron deficient. Another one here is increased usage. Now this could be somewhere else over here, but parasites. People don't realize that parasites love iron. They can also create a little bit of bleeding or ulcers. So let's say H. pylori, Helicobacter pylori. If you have a H. pylori infection that's significant enough in your stomach, you can create ulcers causing a GI bleed. And 2, H. pylori likes iron. So you have a double whammy there, right? And then if you have GI symptoms as of H. pylori, because of H. pylori, because of the ulcer, and you get reflux signs, now they might give you an antacid that you might take for a year or 2 years, and then that depletes more iron for malabsorption. So all these things can interplay, and you can have more than one of these conditions that can create iron loss, okay? So when we look into different signs and symptoms, when we have a patient come in, we have a questionnaire, we ask questions about how they're feeling, right? One of the telltale signs is fatigue. Now, fatigue is a general term, right? It could be due to chronic fatigue syndrome, thyroid issues, etc. But iron deficiency certainly can create fatigue. Pallor, right? Your skin becomes pale and white. Your nail beds become white. If you look under your eyelids, inside, it becomes white. So if you look at the patient's physical appearance, you can tell if they're pallor. Okay? Decrease in cognitive function. Let's say you start studying and about 10-15 minutes into it, you become fatigued. You can't think as well. You can't absorb the material as well. The reason that happens is because of lack of blood flow. Studying takes enormous amount of energy, glucose and oxygen, to make it happen. So cognitive decline, if a child is struggling at school and they can't focus, right, you should actually check for iron deficiency in those children. Dizziness or lightheadedness, right? Dizziness because just lack of oxygen. And lightheadedness because you're not getting oxygen when you get up too quickly, or you bend forward, you get up and you feel lightheaded, right? It's oxygenation issues. Patient might feel cold all the time, right? They don't look cold and it's pretty warm outside. They can feel cold though, right? Again, that can be related to thyroid, etc. But when we feel cold and then you have cold hands and feet, right? First you got to rule out thyroid, but you also got to rule out issues with anemia or iron deficiency anemia. And then you can also get headaches because of lack of blood flow. Like things like migraines is a vascular episode, right? Where it creates issues with the headaches. So iron deficiency can also create headaches because of lack of oxygenation or blood flow. Brittle hair and nails. Poor oxygenation, you're not getting the nutrients to where it needs to be, and your hair starts to fall out, get brittle, and your nails become brittle. In more advanced cases, you're going to get spooning of the nails, right? So, right there, spooning of the fingernails. Canker sores can be a possibility with iron deficiency also, or sometimes vitamin C deficiencies. RLS, restless leg syndrome. So restless leg syndrome is very common with iron deficiency. In other cases, it can be neurological because there are certain parts of the basal ganglion that play a part in restless leg syndrome. Increased heart rate. Your heart will pump harder to get blood flow to the area because of lack of oxygen. So the heart constantly pumps, trying to get more oxygen to a certain area. Shortness of breath, same thing, oxygenation issues, right? Pica. Pica is a condition where a patient might crave dirt. They want to eat dirt, right? Or ice cubes. They just want to crave these weird things because they have a lack of iron. Chest discomfort, all goes with heart rate and shortness of breath and chest discomfort. But you can see that there are so many signs and symptoms that can be associated with this, right? In our office, when patients come in, we have a thermometer, a surface thermometer, where we check the temperature between their forehead, their hands, and their feet to determine, what kind of temperature difference is there, right? Now, if your forehead is, let's say, 98 degrees and your hand is 95 degrees, but your foot is 80, you could have a circulation issue, you can have Raynaud's, you could have a thyroid problem, or you can have iron deficiency. Another way we can check is to check heart rate, obviously, in the office. If someone has a really rapid heart rate, cold hands and feet, then you can start to say, hey, maybe this patient has issues with iron, right? So those are simple ways we can check. And you can also get a pulse ox and look at the oxygen saturation, right? Your oxygen saturation should be above 98%, and in some people it will not be, okay? So on my next video, we are actually going to go talk about the lab tests that are necessary to determine if someone has iron deficiency, and then 2, how do we rectify these matters, right? What natural therapies can we use? What supplements can we use for patients who have iron deficiency? And what underlying mechanisms can you correct in order to help with iron deficiency? So stay tuned for part 2. Today we're going to talk about iron deficiency anemia. Last week we spoke about all the signs and symptoms of iron deficiency anemia, but today we're going to talk about lab markers. How do we distinguish someone who has iron deficiency anemia versus, let's say, a megaloblastic anemia? But today our focus is going to be lab markers for iron deficiency. So let's get right into it. So the first marker we look at is red blood cell. Next one is hemoglobin, hematocrit, MCH, MCV, MCHC, and RDW. So what does this all mean, right? So when we look at this, we have red blood cells, and red blood cells have a concentration of hemoglobin in them, right? So hemoglobin is the hemoglobin in the whole blood. And then you have hematocrit, which is a fraction of blood volume that's intact in red blood cells. MCH, or mean corpuscular hemoglobin, is the average number of hemoglobin in a single red blood cell. So there's many hemoglobin in the red blood cell, okay? MCV is mean corpuscular volume. Mean corpuscular volume means the size of the red blood cell. And what that indicates is when it's very small, it's iron deficiency. If it's very large, it's a B12 or B9 anemia, right? So mean corpuscular volume in size means different things. MCHC is mean corpuscular hemoglobin concentration, and that is the average volume with red blood cells. And then RDW, red cell distribution width, and that's the abnormal variation in size of the red blood cell. So the width is basically from small to large. The wider it is an indication that there are a lot of immature red blood cells and mature red blood cells. So the width of the red blood cells, or the variety of red blood cells, is very large. Okay, so when we look at these numbers here, the numbers in red are indicative of lab ranges. So if you're outside of the lab ranges, it's considered quote-unquote pathology. It's abnormal, right? So anything out of these red areas is a clinical concern. The ones in the brown over here, this is indication of a male and that's a female. And the ranges are different from men to women. So when we look at red blood cell, men is 4.2 to 4.9 and female is 3.9 to 4.5. So the brown indicates ranges for optimal levels. So you can pick up subtle iron deficiency earlier on when you look at the functional ranges in brown versus the red ranges in the lab. So it's a good way of distinguishing or teasing out early iron deficiency when we look at the brown markers, okay? So iron deficiency anemia in lab testing. So these are just a lot of names, right? But at the end of the day, what does it all mean and how do we put it together, right? So when we look at iron deficiency, we just looked at what we call the CBC, right? A complete blood count. We looked at all the different red blood cell markers, MCV, and all those things that are related to red blood cells. There are other markers called iron markers. So we also have to look at, do we have enough iron, serum iron, and then there's ferritin, percentage saturation, total iron binding capacity, transferrin. These are all different iron markers, and there's also a percentage transferrin saturation number too. But when you look at this, same thing, we're looking at lab ranges, and then we're looking at functional ranges, and they can be a little bit different from men to women. So when we look at serum iron, it's the circulating iron bound to transferrin. Ferritin is the storage iron, right? When ferritin is very low, it indicates iron deficiency. If it's high, it can indicate an acute phase reactant, meaning there's inflammatory processes that are going on, and the ferritin number can go high, right? And then total iron binding capacity is the amount of transferrin, right? The one that binds to the iron itself. Transferrin in itself is a primary extracellular protein that transports iron and is produced through the liver, right? That's an important fact because liver function is very important to actually iron levels. So when we look at iron deficiency, the technical term is called microcytic hyperchromic anemia, right? Big words, basically iron deficiency anemia. So what do we see? We just mentioned a bunch of different lab tests, and what do we see when we have iron deficiency anemia, right? So you can have a low serum iron, you can have low percentage saturation, you can have an increase in total iron binding capacity, because basically your body is trying to bind more iron, so the binding capacity goes up. When we have iron binding capacity that's elevated, we start to think about maybe there could be a GI bleed or issues with iron loss. So we can look at reticulocyte count. And what we can do is, when reticulocyte count goes up, we're looking at maybe a bleed somewhere, right? A GI bleed or something else. So the reticulocyte count is basically immature red blood cells. So the numbers keep going up, your body keeps producing more reticulocytes. Ferritin will also be low. Red blood cell will be low. Hemoglobin will be low. Hematocrit, MCV or mean corpuscular volume will be low. MCH will be low. MCHC will be low. Increase in red cell distribution width, and an increase in transferrin, and a decrease in transferrin saturation. So these are a lot of different numbers, right? So in my next video, what we're going to do is try to break it down and to see what is early signs of iron deficiency, moderate signs of iron deficiency, and severe loss, right? Basically, if you have everything here, it's pretty advanced iron loss, right? So iron deficiency anemia. So we're going to discuss that in our next video. And then after that, we're going to discuss how do we improve iron absorption? What can we do? What can we take, or supplement-wise, to enhance our iron absorption and improve our iron levels, okay? My name is Dr. Jin Sung, where clinical excellence meets excellent results, and we'll see you guys next week on the healthy side. Have an awesome day. Today, we're going to go ahead and summarize the different causes of iron deficiency anemia and what lab markers do we look at when we have different stages of deficiency. I'd like to thank Dr. Karazian for this little PowerPoint chart that he provided, and let's go into detail about what is going on with dietary intake. So, causes and stages of iron deficiency. 1. A diet low in iron. How can that happen? Typically with children, when they're drinking a lot of cow's milk and they're not eating a lot of food. So they're drinking 4, 5, 6 bottles of milk, yet they're not eating much of the nutritious foods, right? Then they can develop iron deficiency. Eating disorders, obviously there's problems with malnutrition, and then countries where they have poor nutrition, right? Growth of tissue. This can occur where iron is being utilized in other areas. So when you have pregnancy and you're feeding the fetus, especially in the 3rd trimester, you can develop iron deficiency. Another is fibroids in women, right? Fibroids will grow with iron, and fibroids is one of those main causes for iron deficiency in women. Obviously, things like cancer, colon cancer can be a factor for iron deficiency absorption. Poor iron absorption, right? How can that happen? Hypochlorhydria, or low stomach acid, or the chronic use of antacids, right? When you use antacids, it's meant to be used for a short period of time. But many people are on antacids for years, or sometimes decades. And then that creates an environment where the stomach acid is too low, it does not break down the foods, and it does not absorb your nutrients, including iron, but B12, B9, and other nutrition such as protein, right? So hypochlorhydria is a big problem. H. pylori, or Helicobacter pylori, is a GI infection. It creates an environment that's more basic, and also it creates inflammation. So inflammatory processes, and then H. pylori likes iron. Leaky gut or celiac disease. Now, celiac disease is an autoimmune condition related to gluten. What happens with celiac disease is that it starts to damage the gut lining, and then absorption will be altered. So you have to look out for celiac disease. Parasites, hookworms, pinworms, roundworms, right? These parasitic infections can create an iron deficiency state. Iron loss versus intake. You're taking in enough iron, but you're losing more than you actually take in. And the way that can happen is with GI bleeds or ulcers, right? Or colon cancer, okay? Or abnormal bleeding somewhere that's not detected. So when we look at the different stages of iron deficiency, we look at stage 1. So if we look at the different causes, this kind of correlates with the severity. So from here down, we'll create these types of deficiencies, and it will get worse as we get down into this chart. So stage 1 could be just low iron intake, or growth or tissue issues where they're sucking up iron, right? So stage 1, iron deficiency, all you might see is a low ferritin, which is your storage iron. You might have low ferritin, but you have normal iron, iron saturation, a complete blood count, total iron binding capacity, and transferrin. So everything might be normal, but you're going to start to see a low ferritin number, okay? In stage 2, it gets more severe. So you're going to have low ferritin, low iron, and low iron saturation. And then you're going to have an increase in total iron binding capacity, transferrin, but you might still see a normal CBC, things like red blood cell, hemoglobin, hematocrit, etc. As we get more advanced in stage 3, as we discussed in the prior video, you're going to have low hemoglobin, hematocrit, red blood cell, MCV, MCHC, MCH, and then you might see an increase in red cell distribution with a decrease in ferritin, decrease in iron saturation, increase in total iron binding capacity, and increase in transferrin. So what I'd like you to do is basically have this, or a snapshot of this, look at your blood work, and see if you have any of these numbers, right? If you have one of these numbers, you might have low in the first stages. If you have more than one, you might have stage 2 iron deficiency. If you have all of them, you're in stage 3. And it will correlate with this chart right in here, where you have low intake, growth of tissue with fibroids and pregnancy, etc., poor absorption, and then obviously frank bleeds or iron loss due to bleeding, right? This is a great little chart, and I'd like to thank Dr. K for this chart, and I would like you to wait for the next video where we're going to talk about the different ways we can improve iron absorption and what types of iron we can take to improve absorption in the gut. Excellent results. Today we're going to talk about iron deficiency and how do we improve iron absorption. Iron deficiency is pretty rampant here in the United States, and there are many different causes. And if you'd like to know about the different causes and symptoms, go back to my first video where we discuss a lot of these signs and symptoms of iron deficiency. Today we're going to discuss how do we improve absorption, okay? So how do we improve iron deficiency anemia? One, you have to reduce inflammation, right? Inflammatory markers like CRP, calprotectin of the gut, or ESR can be evaluated to see if we have inflammation. Inflammation will cause issues with iron absorption. So finding the underlying mechanism for inflammation is very important. So that leads to number 2 is correcting the underlying problems, right? There are a lot of different causes, like I said, and if you went back to our other videos, you can see the different causes. However, if you look at it, things like heavy menstruation, fibroids, ulcers, autoimmune disease like celiac, Crohn's, or ulcerative colitis can all impact iron deficiency. So it doesn't matter how much iron you give these individuals, you have to correct or help the underlying mechanisms, right? If you have celiac disease, you can't have gluten. If you have Crohn's disease, it's an autoimmune disease, so you might have to modulate your immune system to dampen the autoimmune process. So you have to go after the underlying mechanisms here before you can give a patient a lot of iron so the iron levels can come up, right? One little clinical tip is that fibroids can be helped with things like green tea extracts, right? Vitamin D and resveratrol. So if you have fibroids, you might want to use some of these ingredients or products to help with fibroids and improve iron absorption. So ulcers are caused due to stress. It could be due to H. pylori infections. So you got to correct the underlying mechanism there. Okay. You have to improve your diet, right? There are a lot of vegans and vegetarians who do it incorrectly and they become iron deficient. So taking in fortified iron is very different from taking in proper heme iron from animal products. So we recommend some sort of animal protein, right? Heme is better absorbed and it's found in seafood, clams, oysters, red meat, organ meats especially. So having proper levels of iron in food is very important. Now, if we're a vegetarian and you're adding mostly plants, grains, etc., you're going to have non-heme iron, right? And then there's also oxalates and phytic acid in there. And what happens with oxalates is that it binds to the iron and it gets excreted out. So there is some issues with that. Now, if you take green leafy vegetables, which is high in iron, and you boil it, then you're going to reduce your iron levels. So the best thing to do is probably steam your veggies and not boil them. You need to take in green leafy veggies, dried fruits, raisins, prunes or apricots, pumpkin seeds, black beans, and there are other things that have iron in them. But again, if you want the highly absorbable form, you need to have some sort of animal protein, or you may need to supplement. At the end of the day, it's not the worst thing. You have to supplement some iron, right? And number 5, right over here, how do we improve absorption, right? Once we get to the underlying mechanisms, as you correct inflammation and some of the autoimmune disease processes and so forth, how do we improve absorption, right? One way we can do it is you take a teaspoon of apple cider vinegar and you put it in water and you can drink it before your meal, right? That improves the acidic environment in your stomach and helps to absorb iron better. So apple cider vinegar is one way, okay? Another is taking some extra vitamin C. So vitamin C is known to help improve iron absorption, right, in the form of ascorbic acid. And then taking certain forms of iron is better than others, right? So the typical prescription for iron is iron sulfate. And they tend to absorb okay, but have more GI symptoms associated with iron intake. So we like to recommend a ferrous bisglycinate chelate, right? It's a form of iron and it creates less GI upset, so less issues with digestive problems or constipation and those types of things. So we would like to recommend that. Liver extract and then hydrochloric acid, right? Hydrochloric acid again is basically improving the acidity of the stomach and helping your digestive process to improve absorption. It's not going to just improve iron levels, but it may also help protein absorption, B12, B9, etc. So nutrient absorption is important. Oftentimes what you find is companies will make supplements or packets of supplements with these products in them, right? And helps to absorb nutrients better. So they've done some studies where they've taken the ferrous biglycinate chelate supplements, right? And you took it and you compared it to iron sulfate, and you can take less of this type of stuff right in here, then you take iron sulfate. So they compared 25 milligrams of the ferrous form right in here against iron sulfate at 50 milligrams. And the 25 milligrams did just as well as 50 milligrams of the typical prescription iron, right? Now there are other forms of iron, such as iron aspartate and picolinate, that can be utilized also. But the one we like to use in our office is this one. It seems to work very well, gets the iron levels up, and then you have cofactors that help improve iron absorption, right? And there are many factors for iron deficiency anemia, but you have to get to the underlying mechanism and then try to improve absorption of iron, okay? My name is Dr. Jin Sung, where clinical excellence meets excellent results, and we'll see you guys next week on the healthy side. Have an awesome day.